Hi, I am doing my clinical presentation. Um, so the chief complaint is that my son has lots of cough and congestion. This is a 4-year-old male patient who came to the office who was with his mom and had complaints of cough and congestion. The onset of this illness started about 2 weeks ago. The patient had already tested positive for COVID on September 11th and retested negative on the 21st of September and as well as today's visit. Patient has had a persistent cough since September 11th. It is a dry cough. Mom has used albuterol nebulizers off and on, but his congestion started about 3 days ago. The drainage that they've noted is moderate, thick, and clear. This patient's not sleeping very well due to the cough and congestion. Mom has noticed a decrease in his appetite, but he still continues to have good PO fluid intake. Mother has been giving him Pediasure and Pedialyte. So he's got a past medical history of COVID-19, no hospitalizations, no surgeries, no non-drug, food, or latex allergies. His immunizations are up to date. His father is lactose intolerant and his mother suffers from headaches and allergies. He has one sibling. His parents live and reside in a single-level home. His mom and father both work a full-time job, and family helps with daycare. He needs minimal to moderate help from the parents, and he does attend preschool. There are no pets in the home. Review of systems. He denies fever and fatigue, no drainage to the eyes, no redness. He does have positive nasal drainage, positive for sneezing, denies pain to his ears, and denies sore throat. Cardiovascular, no, denies murmur and fainting. Respiratory, denies wheezing, but is positive for cough and shortness of breath. GI, no vomiting, no diarrhea. There have been changes in his appetite, but denies pain. GU, there's no frequency and no hematuria. Musculoskeletal, no edema, no trauma, no redness. Integumentary, no bruises, no open sores, no rash. There were no milestone delays, no abnormal movements, no bruising, no bleeding, and the medications he does take is albuterol. So the patient weighs 32 pounds. His temperature was 97.6, his heart rate 116, respirations 28 with an oxygen sat of 93%. He came in, he's active, he's alert, no visible signs of any respiratory distress noted at this time. He does have no nasal no nasal flaring, no retractions, no pulling. He does have some mouth breathing. Skin is warm to the touch. No bruises, no lesions. His eyes are reactive and equal. Ears are TMs are bilaterally shining and intact. No congestion really noted. Nose is symmetrical. No septum deviation, but he does have moderate, clear, thin mucus, bilateral red and swollen turbinates. His mouth is pink, moist mucosa. Bilateral tonsils are a +1, +2. Clear drainage to the back of the throat. No deviation of the trachea, no tenderness to the lymph nodes. Respiratory-wise, he's clear to auscultation to all lobes. Normal chest expansion, regular rhythm, respiratory rhythm. And today, like I said, his COVID test was negative. Cardiovascular-wise, regular rate rhythm. Cap refill is cardiovascular. Heart sounds are with normal limits. No murmurs. Abdomen soft, round, non-distended, not tender, no masses, normal bowel sounds ×4, no problems with stooling, musculoskeletal, 5 fingers, no range of motion limitations. He has normal tone. Neuro is alert oriented with all cranial nerves intact. Diagnostic results, we did the COVID test in the office. It was negative. He is, assessment-wise, is a persistent cough with post-COVID-19 condition unspecified and asthma unspecified. Differential diagnosis is seasonal allergic rhinitis, influenza unspecified, or acute bronchitis. Pharmacologically, the patient is already on albuterol nebulizer treatments. We're going to send him for allergy region 10 labs and to have a chest x-ray done. Non-pharmacological and health promotion of disease prevention. Of course, continue with good hand washing, good PO hydration, minimize exposure to any allergens, can use an alcohol-based hand sanitizer, use disinfectants like Lysol to clean. Education-wise, monitor for worsening symptoms like shortness of breath, increased need for nebulizer treatments, fatigue, dehydration, poor PO intake, or decreased urination. And then just to give reassurance to the parents that the patient will get better with time, and follow up if the symptoms persist more. Clinical guidelines wise, related to chronic cough in pediatrics, is to determine if the cough has been related to 4 weeks or more. There are 2 types of chronic cough, either specific or non-specific. Specific cough is related to an underlying cause, whereas non-specific is they're not sure what the cause is. So some of the most common causes for specific coughs are due to infections such as pertussis, mycoplasma, recurrent aspiration, or protracted bacterial bronchitis. Other less common causes can be due to any congenital abnormalities or anomalies. Signs and symptoms for a specific cough include a cough that's wet and productive, wheezing, chest pain, and hypoxia. A cough that is initiated after the patient has had a choking event. Upon examination, you can see a deformity of the chest wall, clubbing to the fingers, auscultation of bronchi and wheezing, and maybe crepitus. The provider may need to take into consideration the need if the patient is asthmatic, which our patient is. So his asthma should be treated accordingly. He is going to be sent for an x-ray to find out if the results are abnormal for things like pneumonia or foreign body aspiration or bronchiectasis. Depending on what the findings of the x-ray show, there may be other treatments that need to be addressed due to the new diagnoses that may show. Excuse me. At this time, if the patient does have the projected bronchitis, they will start him on a 2-course week of antibiotics, of amoxicillin clavinate. Azithromycin is not indicated for any kind of wet cough, and treatment with over-the-counter cough suppressants and other non-prescription coughs are not recommended. As for another option for consideration as a sequela of COVID, there's something called long COVID, and this is when the patient starts to show symptoms after 4 weeks or more, such as fatigue, shortness of breath, chest pain, and cough. Things that we could have changed was actually, at the time of the visit, he was not showing a lot of shortness of breath. He was not nasal flaring. He was not in respiratory distress at the time. So albuterol treatment in the office was not recommended or needed at the time. Refills probably needed to be sent for the family so that they could know how to deal with it. But with him, it's just going to take a little time for him to heal, and then just for wait and reevaluate.